Welcome, everyone. My name's Av Singh. I'm the Executive Director with the Scotian Cannabis Alliance, and I'm very happy that you are all able to join us on this very special Leap Day. I'd like to, of course, begin by acknowledging the fact that we are on the unceded, ancestral, unsurrendered land of the Mi'kmaq, and I think it's really important that we understand a little bit more about our history, to some degree our genocidal history around our Indigenous peoples, but we move beyond just a land acknowledgement and that we work towards true reconciliation. At the Scotian Cannabis Alliance, one of our efforts is that we are trying to provide regulated product on First Nations communities. And more importantly, we'd like to see that the revenue and the excise tax dollars that the province receives from the sale of cannabis actually go back into those communities. We're also blessed that this is an extra day in February, so we get to also acknowledge the fact that it's Black History Month. And of course, here in Nova Scotia, we've had a long history of over 400 years of having Black Nova Scotians. Actually, I think it's been 35 years that I remember here as an undergrad at Dal, starting the Indigenous Black Mi'kmaq program and the initiative at Dalhousie Law School. And I believe that program has had over 200 graduates that are of Indigenous and or Black Nova Scotian heritage. So there is always that opportunity to make change, and I hope that we in our own industry can start making that change. The cannabis industry is incredibly young, and there's an opportunity to be far more inclusive in that industry. We have still underrepresentation of women and other genders in that sector. The 2S LGBTQ plus community is also underrepresented. So those are other ways that the cannabis industry can become stronger as we increase our diversity. With that, I would like to introduce our speakers. I'd like to introduce Dr. Riley Kirk. Riley is coming from New Hampshire. And after finishing her doctorate degree at University of Rhode Island, where she remains as an associate assistant professor. Her research work, which you're going to learn more about, focused around a very holistic approach at looking at natural medicines and how they impact the endocannabinoid system. So I think we'll learn a lot about holism and natural products through Riley's work. And then we're also blessed to have Dr. Miyabi Shields. They finished their graduate work at Northeastern and then worked very, very specifically on certain enzymes that are involved in the endocannabinoid system as well. So we're going to see a nice mesh between a very reductionist approach and a very holistic approach. And then the two have joined together to form a network of applied pharmacognosy. So I'm going to leave that definition and probably the correct pronunciation to them to discuss. So without further ado, please join me in welcoming Drs. Riley Kirk and Miyabi Shields.
Awesome. Thank you so much, Ab, for that introduction. And this is such a beautiful sized crowd, because if you have any questions during this presentation, please raise your hand, ask them if they're questions about you, your community, how we can understand this medicine better. We are completely open to that and want to facilitate that conversation. So today we're going to be talking about embracing medical cannabis through pharmacology, and I also wanted to give a quick introduction to the word pharmacognosy. This is a word we almost never see. Not many people know what this word means, but our nonprofit is called the Network of Applied Pharmacognosy. So pharmacognosy is the study of natural medicines and natural products, and the word pharmacognosy literally breaks down into pharma, or medicine, and nosy, or the knowledge of. So it's the knowledge of medicine. And it was the first type of pharmaceutical sciences we ever had, because all we had was plants and fungi and other natural products to use as medicine. And this field of study still exists today. It's very active, but nobody ever wants to say the word pharmacognosy. So we're trying to bring attention back to this amazing word with some absolutely amazing history. So we'll be talking about this today and talking about some work that our nonprofit's doing, and a little more about us.
So the two of us are both pharmaceutical scientists, which means that, and we'll go over exactly every part of the drug discovery pipeline and how we fit into there and where cannabis fits in relation to that. But pharmaceutical scientists study drugs. We specifically study drug discovery, like how you would discover brand new drugs. But the thing that actually complements for both of us that we got along the most on is that we're daily consumers. We're both stoners, and we don't consider that to be a bad thing. And we think that lived experience and that the community involvement that we've had with our community through public education, through our lives, through our friends and family, but also through content that we've created to be accessible to other people to learn about cannabis as medicine, has been a uniting and perspective shifting thing that we have shared, from embracing the fact that people want to learn more about cannabis. People want to learn more and have more of that autonomy and self-determination, and also that all of us are doing it anyways, and that we have been shielded from this information intentionally from the prohibition, and that it's been framed intentionally that way. So we came together, we've been working together for almost 3 years now, and this nonprofit is our new venture to study things in the lens of lived experience and to actually study the biochemistry that we did all of our doctoral research on, but in the context of all of us who use this plant every day. So we're currently running the largest and most inclusive study, longitudinal study over time of cannabis consumers. It's ongoing, and there's a link to join it if anyone wants to join later. We're going to talk a little bit about the endocannabinoid system, just a broad overview of why it's so special and how we should embrace medical cannabis through understanding our own endocannabinoid systems. And then about destigmatization, because all of us that are in this room will all be advocates, and in our own lives in some way will be in a position at some point where we will have to either self-advocate for ourselves or advocate for our communities or for our jobs and our professions. And so we're very passionate about using science as a way to communicate, and science as a way to bridge a gap between what we think is a lack of understanding but might just be a prejudice or a stigma that was created by a framing of cannabis in a negative way.
So something that makes our perspective maybe a little bit different than other researchers in our field is that we look at the cannabis plant, we look at medicine under this lens of chemodiversity, or chemical diversity. So if you're familiar with the cannabis plant, maybe you've seen it, maybe you've worked with it, it produces many different molecules, but oftentimes we reduce that to thinking about just THC or just CBD. But the story is much, much, much more diverse than that. Cannabis is a living plant. It's producing hundreds of different molecules. We are also living entities. We are producing many different molecules. Our body is also producing cannabinoids, similar to the ones that the plant is making. But the plant is producing molecules beyond cannabinoids. It's producing other types of molecules like terpenes. If you smell 5 different varieties of cannabis, they all smell differently. Maybe you really like the smell of some. Maybe you hate the smell of others. You're attracted to specific terpene profiles or specific smell profiles. And that actually says a lot about your body too. There's a saying in cannabis, the nose knows. When you smell a specific variety and you say, oh man, that just reacts with my body so perfectly. You have hundreds of smell receptors in your nose that are picking up those smells from that flower. And you can tell when your body is reacting positively to a certain profile or negatively to a different profile. So we need to think about cannabis more than just THC, more than just CBD. I mentioned you have the terpenes. You also have this whole nother class of molecules that was just published about last year for the first time. These are called your flavorants. Flavorants are additional smelly molecules, but they're not terpenes. So they're kind of the smells other than terpenes. These also likely have biological activity in our body. They're changing the way we feel from consuming a specific cannabis strain. And it's not the THC, it's not the CBD, it's synergies within this really complex plant working together to have really profound healing abilities and personalized medicine from learning what product types, what strains work best with your body compared to other ones that maybe don't react well with your body. Another part of this chemodiversity concept that we're talking about, the lens that we're looking at this medicine under, different product types have different levels of diversity of molecules in it. So let's say you have a cartridge with you and it's THC distillate. That is mainly THC. It's like 90% THC, maybe 98% THC, very few other things, compared to a cannabis bud that you just harvested that is fully chemodiverse. It has every single molecule that plant is producing present in that bud right there. And then you light it on fire. And now you have this whole nother level of chemodiversity that you don't get if you're not lighting it on fire or you're not exposing it to heat. Then, of course, you have edibles. Edibles are often made with pure THC, but then you metabolize them. Now you have a different diversity of molecules in your body because your body is processing that THC and it's changing it into different molecules. So understanding the diversity of the different molecules present in the cannabis products that you're taking can kind of help you understand how predictable a cannabis product's going to be, and for some people, how well or how efficacious that product is going to work. Some people react really well to THC distillates. Some people don't like them at all. You might meet people who love a specific strain and you hate it. It gives you anxiety. It doesn't make you feel good. But for them, it itches their brain and just makes them feel comfortable in that way. And we look at cannabis this way, but you can look at all natural products this way. They work in networks. They work in systems. They have many similar molecules present in them. It's not just overloaded with one single molecule. So this is a way I like to kind of show the traditional pharmaceutical model of medicine versus cannabis or the natural product view of medicine. And I'm not trying to bash on pharmaceuticals, this is just typically how we look at medicine, so I think it's a good example, right? So pharmaceutical medicine, you're usually given a pill, and it's at a specific dose, and you take it maybe once a day, and it's just one molecule at a relatively high amount, right? Whereas with natural products, you have many different molecules working in synergy, and sometimes one molecule is going to be a really high amount, sometimes it's going to be a really low amount. It's always going to change. It's going to ebb and flow because it's a natural product, and it's going to change depending on how we grew it, how much water we gave, how much light did we provide. It's going to be ebbing and flowing similar to how our own bodies ebb and flow. And there's something really, really beautiful when you start to transition to the natural product model of medicine. We no longer can make vast assumptions about how drugs work in our body because we don't know. If there are 400, 500 different molecules in cannabis, we have not mapped the exact mechanism how every single one of those active molecules works in our body. But we know it works because we have been tracking the measurable outcomes for centuries, and we know cannabis is safe, and we know cannabis works for so many different things, but we don't know the exact molecular mechanism for every single molecule in that plant. So you have to have a little bit of faith in the unknown. You also have to have the ability to listen to your body and understand if a product works really well in the morning for you but works really bad at night for you, or you take a specific dose right after lunch, but maybe that dose changes at a different time in the day. Maybe when you're 18 years old, you used a specific dose, but now that you're 55, you need to change your dose. It needs to be adaptive. Your medicine needs to be adapted with you as your life adapts. And that's kind of the beautiful part about natural products, because you're not treated like the same person, like everybody has the same lived experience, that your trauma or the way that you grew up didn't shape your brain into specific ways that are going to be different for everyone. We all should react differently to natural products because we all have different lived experience, and natural products are a way to have that really refined, personalized medicine and really get to know your body at a deeper level.
And one of the ways that we came together to understand working together so well is that this chemical diversity that's inside the plants and that's Riley's specialty is actually matched by a chemical diversity that's within our own bodies. And so I'm going to talk about the endocannabinoid system, and I went into it at the other event, and I'm not going to go into it in that much detail now, but this is just one system, and we separate out all these separate systems, dopamine, serotonin, GABA, glycine, we have them separated arbitrarily just because that's how we discovered them being separated back in the 40s to 60s. They're not actually separated. None of these systems are operating on their own, and none of them operate completely in a vacuum of all the other systems. They're all talking to each other, and dopamine, serotonin, GABA, glycine, and the endocannabinoids, which are on the slide right there, these are all molecules that our body has within us as well. So we are equally as chemically diverse, if not more chemically diverse, as the cannabis plant as well. And that it kind of does make sense when you look at it that all life responds to stress through chemical diversity, that this is one of the reasons why we've gotten along with our research perspective so much, because while the pharmaceutical approach has definitely led to valuable drugs and has definitely led to big breakthroughs that are great for humanity, the pharmaceutical perspective is just one way of looking at how we could make the best drug. And we've been doing it for about 200 years in this one direction. And that's fine, and it's valid, and it's something that's worthwhile. But there's alternative perspectives to looking at how we could even evaluate medicine, and we can't put cannabis in with these other drugs, and part of it is because of this system. So the endocannabinoid system is, in my opinion, and I'm biased, the most important system in the brain and body, but it's a major regulator. It operates in the opposite direction of any of the other signaling systems, and that's called retrograde signaling because it goes in the opposite direction. And because it functions in the opposite direction, it is a really important regulator of activity, and it regulates that activity in multiple places, not just the brain, but the immune system and the fat cells and throughout the entire body, reproductive organs. And the three things that you can sum up the biggest pieces of what it can control is overall brain activity or nerve activity, metabolism like fat, energy, and sugar metabolism, and then the immune system, which is inflammation. And arguably, the number one thing that you could say about the endocannabinoid system is that when you activate it, you're going to have an anti-inflammation all over, everywhere in the body, everywhere where the system is, which is everywhere. So those are the three most important things, and they actually correlate really well with the three biggest uses of cannabis, which is mental health, chronic pain, and GI issues, and that they all kind of overlap with each other, and it's why this system is positioned to do so much good and to have such a therapeutic effect for so many different things that we can benefit from. So these two molecules that are here on the screen are endocannabinoids. The left one is anandamide, and the one on the right is 2-AG. And these two molecules our bodies are all making right now. Every single warm-blooded mammal, every warm-blooded animal has an endocannabinoid system, and it's necessary. And actually, evolutionarily, this system goes all the way back to the beginning of life. We started evolving with this system very, very early, and it's a part of many, many, many different processes. And that the way that cannabis works, as you see on the right, on the right, that image is the CB1 receptor. That's part of the endocannabinoid system. It's the receptor that interacts with THC, and that is THC up there in the top. You can see a little wireframe stick molecule of THC. And that the way that THC works is by mimicking these other two molecules on the left that our body makes. So when you have a benefit from cannabis, what you're experiencing is the cannabis has a molecule in it that is making your body feel like it has more endocannabinoids present, and that's part of how you get that therapeutic effect just with THC on the CB1 receptor. But just like in the plant, we are still at the point where we need to have some faith in the unknown here, because there's so much about these systems that we don't yet understand. There's so much. When I point to these two endocannabinoids, there are actually so many more molecules that would fit under the standard of things that interact with this system. They're called the endocannabinoidome, or lipidome sometimes, or elmeric acid sometimes. They have different names, but they're more minor molecules, but they exist. And that there are these interactions that happen on a smaller scale in the body, in a diversity or in a concert together, that we also have yet to understand. And so the one thing that we do know that we've looked at into the system is that this system, the endocannabinoid system, is dysregulated in almost every single condition that we've ever seen. There's a form of dysregulation. Now, the question is whether that's a chicken or an egg situation, right? Does the dysregulation of the system come from some form, like either if it's cancer, an autoimmune disorder, et cetera, or is it the other way around, and does that disorder cause that? Now, the real answer to that question, I don't think we'll ever probably know. I don't assume that we're gonna know it in our lifetime, but what we do know is that cannabis works, and that cannabis works through this system on a huge number of these things, on almost anything that is flare-based and has anti-inflammatory or like stress as a component. You could argue that cannabis should be the first line for all of these things, because we know that there is a valid system that it's working through that causes these effects, and that actually, if you look into every single one of them separately, there's evidence in the scientific literature for why that would work and why it would be efficacious. And so the real question is whether or not we are going to need to evaluate it differently. And that's what we think we need to do, and that's part of our approach as scientists and working together.
Yeah, so I won't, reintroduce this theory of chemodiversity or why it's so important to look under this lens, but it is important to think about how complex your products are and how much control that we as users have over the products that we're consuming. We often talk about the type 1 flower, THC dominant flower, right? But there's other types of flower that's dominant in other active molecules, other active cannabinoids like cannabigerol or CBG dominant flower, CBD dominant flower, THCV dominant flower. And what this means is that these flowers, this bud, it doesn't necessarily get you high. It doesn't need to get you high to have the medicinal benefits. And something that I talk about all the time is talking about med patients versus recreational adult use patients or people. Is there really a line there? And something I say all the time is, if we are using a medicinal plant, we cannot choose when it's medicinal and when it's not medicinal. If we are all taking in a medicinal plant, it has medicinal value. As Miyabi just mentioned, it's lowering inflammation. It's lowering cortisol levels. It's increasing our quality of life. It's making us better parents. It's making us have more fun. It's allowing us to enjoy life when this day and age, a lot of people are struggling with that every single day. So we do believe that there are evolutionary and pharmacologically relevant benefits to having these really diverse products. And we're going to talk about adverse effects later on in this slideshow. And I think this is going to come up again. As most adverse effects that we see from cannabis tend to be when we have less chemodiversity, when we're heavily concentrating products. And I'm not saying anything bad about concentrates. I dab all the time. I love concentrates. But sometimes when we lose that respect and that intention with our medicine, it does lead to some sort of dysregulation in the opposite direction, right? Too much of anything, and especially too much of anything without intent, can be harmful. And that's an important conversation to have in cannabis, because I think a lot of times we get defensive about this plant because we do believe it can heal the world, and we do believe that there's so many different medicinal benefits to having this amazing plant that acts in a system that can bring regulation to dysregulated systems. That's the entire point of the endocannabinoid system. And that's why it's good for literally everything. It can bring balance or homeostasis to dysregulated systems. All right, so we're going to talk about kind of what we're doing and how cannabis essentially fits into the drug discovery pipeline that we traditionally use for pharmaceutical drugs. And just to reiterate kind of our backgrounds and how that fits into the pharmaceutical discovery pipeline, both Dr. Shields and I, our expertises are in the first step of this pipeline, which is drug discovery, is learning how to find new drugs, because we don't have enough, I guess, right? So we got to find new drugs. And my job was to look at natural sources. So I was screening, I made a plant extract library. I looked at bacteria, algae, diatoms, fungi, all these different sources of natural products to find new medicines. And then Dr. Shields was focusing on the drug discovery targets, or what's going on in the brain. How can we figure out where are these different molecules from nature, where are they acting on the brain, and what is the medicinal potential of a certain drug on a specific target?
So now I'm going to talk a little bit about how cannabis fits in with all this, because one of the things when we met that we were kind of on the same page about as daily consumers is that if we spent our entire scientific careers looking at that beginning part to discover new drugs, identifying and investigating natural sources and identifying drug targets, if you put our PhDs together, it's like a no-brainer that we've already identified cannabis as a source for natural products that have extremely high therapeutic value, and that we already have identified targets within the brain and body that are dysregulated in states that we could be treating to get the benefits from cannabis. So I'm just quickly going to go through what the rest of these are and how that looks. So for us in our field, it's pretty much a no-brainer, even though it doesn't seem like other pharmaceutical scientists agree, but maybe we'll sway their mind eventually. So far, I think there's like a third pharmaceutical scientist that we've met as well. But again, we are trained in this pipeline to look at drugs this direction. So after drug discovery comes preclinical data. Preclinical means like non-human, so that would be like all sorts of animal model data. In my opinion, and this is a little out there, but I'm just gonna say it, if we're doing animal level data on cannabis and cannabinoids and terpenes, I think that that's a waste of resources, because we should be doing human data, because all of us are doing this anyways and we already are using it. It's safe. It's a way more relevant data set for us. And it's definitely a self-motivated belief of that, because I believe that looking at my own self has taught me so much more than I think any animal study would be able to do. And those animal studies are extremely expensive, and we just have limited resources for research. So preclinical data, I don't think we need for cannabis. I don't think we need more mouse studies at this point on the safety and toxicity of cannabis, or on like long-term uses of cannabis, because I think that we could always have more information, but let's just find that out in humans at this point. So clinical data, clinical is defined by like highly controlled, usually through hospitals or hospital settings, like dosing procedures. And I think that that part is definitely valuable, and we should have clinical studies, and they should be done in that way. I also think clinical studies are difficult because they're usually not open to the general population. They're usually for very, very specific things. And if you look into how the people recruit for clinical studies in pharmaceutical companies, that gets complicated as well. Do I think that there needs to be more clinical data on cannabis though? Also, no. But I think that that's because we already have a lot of information on some of the like most important clinical metrics of cannabis that we're assessing for. Could there always be more clinical level data on everything? Absolutely yes. But what information do we actually need within our community to provide the best medicine and to provide the best treatments and dose protocols for patients and for people? At this point, it's real world data. It's like things that are outside of a system that is so controlled, because the real world isn't controlled. And then the last two, I think, are things that we are battling within our industries, depending on where you are, what location, the maturity, the market of all these industries anyways, and the levels of regulation of the places that we're in, because we're from the US. It's very different there than it is here. State to state for us, it's very different as well. Different countries are different as well. So manufacturing and quality control, those are things that our industry is definitely figuring out right now. There are things that are very important for us to be standardizing and like developing protocols for. At the same time, it's already happening and it's been done, and it's something that we need to work on in terms of just like open communication and standardization. But this isn't a science issue. We already also know that the biggest part of the science issue of these two things is maybe just the documentation, because things have already been going on and been done for a long time, and we haven't preserved or valued the information that has happened before. And that's something that the reason we haven't done it is because cannabis cannot really ever fit into this, because if we were, it would have to be every single molecule in cannabis going through it almost individually, instead of having the whole thing go through it all together. And that's one of the reasons why we want to approach our research in a way that's more geared towards the plant and what people are actually doing with the plant, and research that's relevant with these really complex combinations of molecules. New products like live products, new products like diamonds, new products like, rosin's relatively new actually, right? New things, like very limited research on those things. And that we think that that's where there needs to be the most effort and information put in, because the market's evolving much faster than academic research can keep up with. And so in the nutshell of what both of us found is like one of the most important things to communicate is that Cannabis is extremely safe, has a low toxicity profile, and is really, really efficacious. And it's really important to keep this in mind when we're going to talk about the next slide. We will talk briefly on negative and adverse effects of cannabis. But that if you look at our backgrounds pharmaceutically, like how do pharmaceutical scientists really evaluate the safety profiles of drugs? It's usually about, it's a number. It's a value number of how much of this drug will it take to kill you, divided by how much of this drug does it take for you to feel anything, right? And so that's a safety profile. And actually, there are a lot of pharmaceutical drugs that are quite common that have pretty poor safety protocols. We were talking about Tylenol earlier today. And when it comes to the safety of cannabis in that way, it's unlimited. There's still to this day has never been an acute overdose. And it's highly efficacious. Most drugs that make it to clinical trial, they will fail most oftenly for efficacy, which means that they spent billions of dollars to get them to clinical trial. And then the reason why those drugs failed was because they didn't actually do enough of the thing that they were supposed to do to help. So we already know these two things about cannabis, and that was definitely something that it's difficult for us to have conversations with scientists about relative harm and things when we don't take that into account as kind of like the first piece when we talk about negative effects.
And I think it's important to put this in context when we think about the safety of cannabis, because of the legal infrastructure and how much propaganda and how much negativity has been put out about cannabis, and still is in some areas, I think oftentimes we expect it to be safer than water. If we want to make it, federally legal, it needs to be safer than water. It needs to be absolutely safe for everyone. But how do we expect to have this medicine that helps millions and millions of people, that helps with so many different conditions, incredibly efficacious, but also there's absolutely no way ever that you could have a bad time with cannabis, right? That doesn't make sense. If we look at any bioactive compound, biologically active compound in nature, or even a pharmaceutical drug, there's always a balancing act between, how efficacious and how safe. And cannabis's profile is absolutely insanely safer compared to almost every other drug and active compound that we have on the market. So we're going to talk about a few negatives of cannabis, because this is important, especially for public education, to know about what to be aware of, and also for your community, for your friends. This is important. CNN released this big publication about cardiovascular health and cannabis sometime last year. And I had many conversations with many scientists about this, looking at their data, but also having the nuanced conversation of, okay, but people have been using this medicine for thousands of years and we've never seen this trend before. We know it's so safe. And of course, if people have pre-existing conditions, and that's really what the theme is for all of this, if you have pre-existing conditions, you do need to be hyper aware of what's happening in your body and how to look for warning signs. So whether that is cardiovascular health, whether that's lung health, whether it's cannabinoid hyperemesis syndrome, whatever, or mental health. If you have a history of schizophrenia in your family, that is something to be aware of and to use in a more intentional way, and to have those important conversations as you are getting into this medicine. So we won't talk about these all really in detail, but kind of what I mentioned before is we need to realize that every cell in our body, every organ, every tissue has cannabinoid receptors. Our endocannabinoid system is woven through our entire body. That's why we can put a cannabis topical on our leg and it can provide relief and reduce inflammation. Or we can use a suppository and our lower body can find relief. Or we can use a tincture sublingual, or we can smoke it and we can feel those effects immediately, right? We have so many different tools. And if you're worried about this, or you have family history about any of these things up here, maybe you need to adjust your dose, your tool, your consumption method, the people you're around. There's ways to kind of decrease the events of adverse effects, but we need to understand how this medicine works in the body first, and we need to make sure we're still respecting this medicine. Even after we've been using it for years, even if it's part of our life, we still need to respect the medicine in order to have a positive relationship with it, and always be able to ask ourselves if that relationship is getting off kilter, so we can make sure to bring regulation back to the system that's bringing regulation to us.
I think keeping in mind the net benefit is really important when we're looking at all this, because like you said, why are we expecting it to be safer than water? And also, if you drink too much water, your head's gonna swell and you're gonna die. So if we're looking at cannabis as like when we often research it and we're saying that there are increased risks for these things, we are often considering that the alternative would be nothing. But that's not really true. Typically, cannabis is replacing something or decreasing the use of something else, like alcohol, pain meds, or anything else, like any number of pharmaceuticals. It's not common for it to just be cannabis or complete sobriety in the world. And so there are also all these other factors that come in when we think about what the net benefit of a medicine actually is. There's tons of research that shows that increased stress levels in general are negative for health in general, right? And we don't take those things into account. And personally, just talking about the psychoses and mental health part of it, that part has been stigmatized like crazy. I guess I probably shouldn't use that word when talking about that especially, but that, the psychoses and mental health aspect of cannabis, there's clearly a correlation. A correlation means that there's two things that are happening at the same time, and you can see that they're correlated. You can see that there are more people who use cannabis, especially if you start using cannabis young and use it over a long period of time. It is true that there's a higher percentage of people that fit that need that eventually end up getting diagnosed with schizophrenia. But it is also true that cannabis, THC, cannabinoids, synthetic cannabinoids, have all displayed anxiolytic, decreasing anxiety, antidepressant, decreasing depression, and antipsychotic activity. And I'm not just talking about CBD. There has been research that's been done on agonists, or things that turn on the receptors similar to cannabis. And I do believe THC has even had at least 2 publications of animal model studies that have shown this. And just from my personal experience I've been diagnosed with pretty much everything. And when cannabis saved my life, I got my PhD so that I could understand why it worked for me better than those other drugs. And the truth is that those other drugs have their own negative effects. And all of these toxic or potential risk effects that we have for cannabis, the alternative medicines also have adverse effects, and we need to keep that in mind when we're talking about it. And one of the issues that we hope to address and that we want to share some data for our first study is that the academic and medical research communities have never looked at our population, which would be high needs medical consumers. People who consume daily are high needs medical patients. And we've actually never been researched under a neutral lens. We've always been researched as addicts, as substance users, as degenerates, as morally fallible people. I'm treated that way every time I go into a doctor's office. And so if we're getting framed this way in the research, then we're not gonna have certain insights into the research that we need. Our population is actually the most knowledgeable population on cannabis. And those of us that have the most lived experience with it actually have the most detailed information to give back to science on the quality of the medicine and on how we can continue to improve it and continue to strive to learn more about it for all of us.
So the first research study that we completed was really learning from the population of people who has used cannabis for a long time. And essentially what we wanted to do was a longitudinal study. So over time, we wanted to follow people and understand what their consumption patterns were. We've never had any data understand what the average consumer might be like. How many times does the average person consume cannabis in the day? Do they prefer inhalables, topicals, edibles, suppositories? We're not really sure. So we first started this study and we advertised for it on social media, through dispensaries, through cannabis events. And what we did is we took just baseline data first. We wanted to learn more about this demographic in general. Learning just about their brains, asking questions like, do you have an addictive personality? And by the way, this study's still open. We'll put a QR code up at the end if you want to participate. But after that baseline study, then they start a 2-week-long survey, essentially, where every day you get a text message that asks you about your consumption patterns, asks you when the first time you consumed cannabis in that day was, how many times did you consume? Did you consume concentrates or flower? Did you consume any other ways? Was it THC dominant? Was it CBD dominant? Or was it dominant in something else? So we asked people, the data we're going to show you today is about 4,500 people, and that number is about, I think, up to 6,000 or 7,000 people now. So we'll be reanalyzing the data soon. But this is in collaboration with our technology partners, and we found some really surprising but also really enlightening information from the study that has never been investigated before. The first thing that was absolutely the most shocking to us was 91% of the people who took this survey consumed cannabis every single day. That might not be shocking to you if you're one of those people, but for people who aren't super aware of the cannabis community, I think a lot of people thought, oh, maybe when they're having a flare-up, or maybe on Wednesdays if they get out of work early, they light up. That's not the case for us. We're using this medicine as a medicine. We're bringing balance to our body and using it every single day. And the amount of comments that we received saying that this was the most validating piece of data because they had this inherent sense of shame from being a daily consumer of cannabis. And they weren't open about it. They were closeted from being a daily consumer because people treat them like drug addicts. People treat us like drug addicts. And it's okay to be dependent on a medicine. If anybody's taking a pharmaceutical medicine, you're given a pill and you're supposed to take it every single day. If you don't take it, dysregulation happens because all of a sudden you had this medicine, now you don't. That is a tolerance break. I mention this a lot, but tolerance breaks, they can be good or bad, but sometimes they are rooted in shame, that you cannot be dependent on this medicine, and you need to make sure that you aren't dependent on it, that you can still live a great life without cannabis. And honestly, as a medicine, we don't think about that with any other pharmaceuticals. We wouldn't take a tolerance break from any other medicine. So why are we making ourselves do it for cannabis, right? And that's not the same as taking a tolerance break to reevaluate your relationship with the plant, or maybe to actually lower your tolerance so that medicine works better. That's different than the inherent shame that we sometimes get from other people or society or even our doctors if we are dependent on this medicine. And this is really important to understand pharmacology, or how these different molecules work in your body, because you can understand how to take tolerance breaks that still do lower your tolerance, but you can still supplement your endocannabinoid system at the same time. So this goes back to using CBD flower or CBG flower that doesn't have THC in it. So you're still not going to be hitting those receptors as hard, and you're still going to be able to reset your tolerance, at least to some degree, without having to compromise your quality of life. Right? So the more that we can talk about this as a way of using science as advocacy, to say that we have the science to know that this plant is amazing and it works for so many different things, but also that you don't need to choose between being happy and consuming weed. Like you're able to consume cannabis, reset your tolerance, still increase the quality of life. The second part of our data that we found that was very, very interesting was that 64% of the respondents consumed cannabis before noon. This is another thing that I think a lot of people in society don't think that's happening, that the majority of us are waking and baking. We are waking up our endocannabinoid system is at its all-time low in the morning. You don't have a lot of those endogenous cannabinoids that are activating that receptor. So many of us need to supplement our body in the morning because that might be when that medicine is the most important and is going to work the best. But again, to society, people who wake up and smoke weed, not a good look for a lot of what people perceive our society to be successful and to be, a functioning member of society. There's no way that you can wake up and smoke weed. But 64% of these 4,500 people did wake and bake, and both of us are included in that 64%. So it is medicinally relevant to consume in the morning, and we really need to understand that as a medicine, that most people are taking their medicine in the morning. It's fueling your cells for the day. It's setting a precedent of how you're going to feel. This last piece of data, has anybody heard that some people can't feel edibles? Yeah? Okay. Is anyone in this room not able to feel edibles? So our data says that up to 16% of people can't feel edibles. This number might seem really, really high to you, but we've actually taken data on social media with more than 20,000 people, and the number we got on that separate survey was around 18%. So this was actually very validating because we're going to peer review publish this data, and for the first time it's going to be in literature that up to 16% of people can't feel edibles. Can you imagine if there was any other medicine out there that 16% of people couldn't feel and we just didn't research it because we don't care about them? That would be absurd. And that's what's happening in cannabis. And we need to fund studies to understand how this is happening. There may be a way around this. There may be a way to formulate a product so that maybe it's only 5% of people who can't feel edibles after that. We can bring this number down with research. But the problem is, the research, oftentimes we don't even know this is a problem in our industry because we're not asking the stoners about their experience with cannabis because we've kind of neglected the opinion of stoners for so long because academic research has really been the gold standard for so long, and it's typically those communities don't really interact, or the opinion of cannabis consumers is not respected because we're thought of as drug addicts in society, right? So this is really important that we dive into these questions more, and this is something that our nonprofit is super incredibly passionate about, is finding the right ways to study this data and then to communicate it back to people. So if you are in that 16%, you can know that somebody is doing research on that, and maybe we will have an answer, or maybe you'll just figure out why you can't feel edibles. You know, we want to make sure that people feel that they care, that we care about their experience. Yes, there's a lot of theories. I'll say a couple. Okay, so one theory is we all have these liver enzymes, but there's a bunch of different types of enzymes, and the bunch of different types are called liver isozymes, these different types of liver enzymes. The purpose of these liver enzymes is to take the THC that you put in your body through a gummy, process it, make it actually into a different molecule that hits your brain a little bit harder, and then eventually you're going to metabolize that again into an inactive form, and you're going to excrete it, right? A thought is that some people don't produce enough of those specific enzymes, or maybe don't produce those specific enzymes at all. So they're not able to convert THC into these other forms, which allow us to feel the effects from them. So it has to do with differences in liver enzymes. And that's kind of a genetic component more than anything. So you might be worth, if you don't feel edibles, to ask family members. Do they feel edibles? Do your siblings, do your parents, do they feel edibles? You know, that's another clue that we can start to learn from and design future studies for. Another one would potentially be your gut microbiota. Everyone has different gut microbiota. Some of us have certain species of bacteria that are much higher than other people, and some drugs and supplements can get kind of pre-digested in your gut. And it's thought of that maybe perhaps that might happen to some people. Some people might not be producing enough bile acid, which is part of the metabolism process of fatty foods in general that allows those molecules to get into your bloodstream. So that's another potential hypothesis. If you're not producing enough bile salts, you might not be able to actually process and feel the effects from. But again, we don't really have this data. This is all hypotheses based on other drugs and other things that have happened. We don't really have this data for cannabis.
And I just want to say again that, like, if we were to put the resources and the money that we are currently putting into looking at, like, what is harmful about cannabis, if we've even put a fraction of that resource and that funding towards things that are tangibly going to, like, affect all of the consumers, we would have this data, like, by the end of the year. Like, it's not a difficult thing for us to look at. It's something that has been done with other drugs, very often. And I literally cheered out loud when Riley read me a couple of these first, like, did the analysis before me. We were recording a podcast, and I literally was, like, cheering out loud hearing that I felt represented. Daily consumer, and the majority of people consume before noon. That's something I've felt a lot of shame about. So this is just a little bit about the demographics and about seeing myself in the research, and also about, a little bit of a caveat that we want to say is that we have a self-selection bias in the people who have completed our survey. We have sent it out through, like, dispensaries and through email listservs. Public events, right? Like canvassing, like both of us sending it to all of our friends and family and telling them to send it to everyone. But we've also announced it on our social medias, which means that the people who follow us and listen to our education are going to be a larger population. That being said, our data points to high needs consumers, daily consumers, as multiply socially vulnerable people, that they're overlapping. And this doesn't even take into account, like, any of the ethnicity data or, like, location data that we have of whether cannabis is accessible where people are. And it kind of makes sense, because for most of us who do consume daily, or our communities and our friends and family members who consume daily, typically that person has some sort of chronic issue. Typically there's more than one chronic issue that is contributing to the reason why cannabis is so regulating. And so it also makes sense that we would be socially vulnerable in more than one way. And this was something that we were surprised to see, but it was something that was, like, surprising, but also very telling. And then when you thought about it, it wasn't surprising at all. And so this is just a breakdown of how people use products. Another caveat about the whole research thing, we spend a ridiculous amount of money looking for like the negative aspects of smoking. Smoking is my preferred method of cannabis use. Flower will probably always be my preferred method of use. Does that mean that I think it's the healthiest or the best way or the thing that I'd advocate for other people? No. Definitely not. Dryer, vaping, edibles, like there are clear advantages there when it comes to like the cleanliness of things versus like combusting, right? But at the same time, smoking is a unique experience. Dabbing and vape pen, they're unique experiences. Inhaling has a different dose profile, and it is by far the preferred method of consumption for most consumers. And I believe personally that it has different effects on me, and that's the benefit of those effects are way better than paranoia that I get and heart palpitations from having edibles. And that's just a sensitivity that like each of us can have different sensitivities to different methods because of the chemical diversity inside the plants and inside our bodies. So 12.9% of people using edibles and only 3.4% of people using topicals. Oops, I should say topicals. Topicals are such an important and valuable thing. We were pretty surprised by that, and that most of the people who use topicals only apply them once per day. Let me tell you, we got a sample on Tuesday of a topical that was incredible. That thing is pretty much gone. It's pretty much gone. Like that's how often topicals make sense to apply. And so this data is really important because it shows us whole like gaps in our public education, especially if we are providing products for people, like things that we could let them know about different products. But it also drives research because, yeah, we could look at like the negative things about flower and concentrates and smoking and inhalation, but we should dedicate at least some research towards the positive therapeutic benefits as well, because it is a majority, and there's multiple reasons why it would be a preference.
I also want to bring this up because this was a question that was kind of brought up before this, but I think it's really important about dosing and how it does ebb and flow with your body, your current status of how stressed you are, if you had a traumatic event recently, if you're older versus younger. I hear people come up to me all the time and say, I used to just chief on weed when I was younger, but now that I'm 55, I get crazy anxiety from it. And yes, that could partially be due to the cannabis. It is much stronger now than it was, 20, 40 years ago. But also your body is changing. And we don't think about that a lot, how the level of receptors is changing in your body. The levels of endocannabinoids are changing throughout the day. And this is really important for dosing. Actually, can you go to the next slide? So we're going to talk about the wake and bake again, but it's okay to have different dosing depending on what time of day it is and how old you are and if you're with different people. No, don't be sorry. There's definitely impact. Do you have like numbers for this study? I know that there's different impacts because people who are female assigned at birth typically have higher levels of fats in their body too. And endocannabinoids are actually made from fats. So sometimes women might require a lot more cannabis than other people. Your fat actually has cannabinoid receptors all over it as well. Even your reproductive tissues have cannabinoid receptors on it. But I don't know if we have any like numbers of how that changes.
The female reproductive system is also just understudied, period. Like that also just needs, and actually maybe just to say assigned female at birth in general, even at the mouse level research is underrepresented, period. Because it's very difficult to study people, like to study any animal that cycles hormonally, there's huge changes. The endocrine system, the system for hormones it changes a whole lot of things. The one thing that I've always found really interesting is the change in pain perception. That's fairly well documented throughout hormonal cyclings, that there's like, you become sensitized to pain when you're menstruating, for example. And then ovulation would be another time that there's like big shifts, but that these large shifts in hormones clearly cause large scale changes. I know that this is like qualitatively known throughout the community that there are changes in your sensitivity to cannabis throughout your hormonal cycles, but there, to my knowledge, hasn't been like detailed studies on individual people in their individual variability. That would be something that we are definitely interested in pursuing. So, like, it's definitely something we're going to do. Every single one of these things that we're pointing out in this initial less than 1 month analysis that we've done on this study so far is something that we want to take further, and that part of us doing this research is to point out that we need to, and that we should.
But that is a great question. Yeah. And then a second piece of data that we'd love to share is about how often people are dosing per day. And something I brought up at the last event, and I think it's really important to bring up, is how many people are consuming 4 to 5 times a day and what our public perception of cannabis and driving is. If we're talking about people consuming 5 times a day, they likely have a pretty high tolerance for cannabis and they're pretty comfortable with how that makes them feel. We had a piece of research come out just a few weeks ago that showed that as people's tolerance increases to cannabis, their motor function actually was fine when they had a high tolerance. It was really just people with low tolerances where their motor skills were impacted by the use of cannabis. And these are conversations that are really difficult to have, but we need to understand that people's brains are different when they are daily cannabis users. We have less cannabinoid receptors in our brain because we've built a tolerance. So the same amount of cannabis for a new user versus a very seasoned user of cannabis is going to impact them incredibly differently. And it's not linear like driving and alcohol, where you can almost just draw a line to say, okay, if you consume more alcohol, you are going to be more effed up and not able to drive, right? Your blood alcohol is going to increase with the amount of alcohol that you've consumed. That is not the same with cannabis. It's actually not linear at all. So we need to stop trying to take these other methods and try to apply them to cannabis when they don't. We need to be innovative and we need to look at the data of what's actually happening. Motor vehicle accidents do not increase, at least in the United States, in states that legalize cannabis. But we keep searching so hard to find ways to acutely criminalize people for this. But it's not really a problem. I'm not saying that's not something we should research, but we need to understand the different impacts of the problem and how our stigmatization of cannabis is shaping the way that we fund these things and how much attention that we pay to specific issues. So again, another just great advocacy point here is that people are consuming multiple times a day. Again, with any medicine that you're using as a medicine, you'd be expected to essentially find a new steady state on that medicine. You wouldn't just consume it once a day and have those effects last an hour and then not take it again. It makes sense to continuously dose yourself to stay in that new steady state that you want the most medicinal benefits from. These are just some data on general doses that people are using for both flower and concentrates. For anybody who doesn't know what a concentrate is, it's typically an oil, but it could be other products like rosin or live resin that have a higher concentration of cannabinoids like THC, CBD, and others. And what I thought was really cool about this is we actually provided people a way of measuring their dosage, which I've never seen before. But as we were making the survey, we were like, how are people going to know that they're consuming a half gram of flour? Like, nobody weighs out their flour before rolling it up. So we actually had a rolling tray with a bunch of different rolling papers and different amounts of flour on it so people could understand what their dose is. And for the first time, people are actually attributing a certain dose with a certain feeling and being conscious of their consumption. So we're going to show a few patterns here, but specifically in the smoking dosage, you'll see that there's kind of 2 distinct bumps. And we see that similarly with edibles as well, but with concentrates, people are typically consuming really small amounts of concentrates, which is something that we expected to see in the data, but some people also require very high levels of concentrates, and that's oftentimes your chronic pain people, maybe your cancer people. You know, we need high levels of cannabinoids, and that's absolutely okay.
So this is just the edible dosing data, and there's it is similar that there's these 2 sort of peaks. I'm like way to the left where like I can barely take like a milligram of THC like with a hemp edible before I'm like, no, I prefer to smoke. But some people take hundreds of milligrams as just like their baseline. It's something that whether or not it has to do with the metabolism or whether or not it has to do with how sensitive the brain is to that metabolite, or we were even talking about yesterday whether we know the location of where this metabolism happens even within the liver. These are all things that we still have yet to understand. But one thing I want to point out about edibles is that it's the gold standard for pharmaceuticals for the route of administration of a drug into the body, because it is dosable and it lasts for a really long time and it's really discreet. And so for that reason, like, edibles are totally valuable, and I wish that I could feel them and benefit from them, but there needs to be more research done on that. So there are two groups of people. If you look at like the edibles and the smoking data, that in general there are low responders and high responders to cannabis. Low responders need high doses, and this is like a funny example of a space where Riley and I are both in the low responders section for smoking, but we're actually in the high responders section for edibles. So you don't have to be in the same group for both. And that there are some people who are, right? There are people who would be sensitive to both. There are people who would need higher doses of both, but that it is and can be different, at least in this case. And that high responders need lower doses and will be like more in that like one bowl or like one gummy a night. And then the other question that I just want to posit, that I used to be under this high responders need low doses, or at least I thought I was for like quite a few years, but I'm like 3 months into an experiment where I'm retitrating what I think is my therapeutic dose of cannabis. And really the end statement of the first 3 months, and I've got like 7 more months to go, is that I haven't been smoking enough weed for the last like at least 5 years, like at least halfway through my PhD, right? I should have been using far more. So a real question too comes with, is a piece of this also have to do with the stigma? Or how much does this stigma and how much does our social perception of our own medicine dictate what we do and do not allow ourselves to feel in terms of relief and in terms of quality of life?
All right, we won't spend too much time on this because we just spent a bunch of time on some other slides that said the same thing, but we'll just repeat. So there are two distinct populations of daily consumers that we see in our data. There very well may be way more than two populations of people, distinct populations. But we call them low responders and high responders. I think all of us here probably know a low responder and a high responder. People who seem to get extremely high off of one puff or like a 2.5 milligram gummy, or people who can, smoke all day long and they're just kind of staying in that steady state, or take 100 milligrams of edibles and they feel the same way that I would taking 5 milligrams. A majority of daily consumers initially dose before noon, and a significant portion of daily consumers dose 5 times per day. And I think a really important part of all of this, and something that we've been talking about kind of this whole trip in Nova Scotia, is we're not sharing all of this for everybody to come out and say, oh my gosh, I'm neurodivergent, I'm not consuming enough cannabis. We're doing this to use this data as an advocacy tool and to understand the right language, some data points that you can share when you're talking about your cannabis use with other people and say, oh, you think it's weird that I wake and bake? Actually, 64% of people in a 5,000 person survey also wake and bake, right? You can feel part of this community and you can feel seen in the data, which is the goal of this initial study, and we plan on going so much deeper into all of this research. But our data supports cannabis as a therapeutic accommodation for multiply disabled, socially vulnerable, high-needs medical cannabis patients or daily consumers.
So if 64% of people take the first hit before noon, if 32% of those people are hitting it more than 5 times per day, then that means that 20% of people are daily consumers who take their first hit before noon and who dose more than 5 times a day. And that's a significant population. We are both part of that population, and that we in general find that, again, the end goal of this is not to come away with it by saying that cannabis users are weird brains, although we are in the best possible way, in my opinion. What we can come away from this is that, high needs medical patients exist. Whether or not we consider that use even medical or not, this is a benefit. You can't choose whether the plant is medical or not, or whether the plant has medicinal value or not. It does. And that when we are being actively discriminated against at the professional level, at the personal level, at the legal and financial level, whether or not this has to do with prohibition and a vector for discrimination for people to arrest certain types of people, or whether this also has to do with banking and whether or not companies can acquire necessary resources to do business as an industry to provide medicine. These are real consequences that we are facing, and that the reason for these consequences comes from us being viewed as a socially deviant class of people, when the reality is that we are just a group of people who require an accommodation, and that accommodation is cannabis for a happy and healthy and beneficial life that is, in my opinion, was never made clear to me that it was worth living until I experienced cannabis. And so, thank you. And so this is something that's really helped us in our study, that has really helped us, is hearing from everyone else and hearing from what everyone has said about this research, but that our study has also helped people be more aware of when you bring science and you bring this different level of consciousness and intention to your dosing, that you can have these insights on your own. And that is the ultimate goal for both of us about public education, is to be able to help people to gain access, to be able to like get the biggest benefit for themselves, because there's no way that any one of us is going to be able to really tell someone else what that is without knowing what the experience is for them or knowing them incredibly well.
So these are just some quotes that people have commented, sent us, emailed us. You know, your study directly shows me how much my non-consumption days are difficult mental health days. Your work is going to help so many people gain access to the plant. And, you know, we don't need to read all of these, but kind of what Miyabi's saying is we knew this work was impactful, but this data has never been collected before. It seems pretty rudimentary. But guess what? We're missing all of that type of data for cannabis because we've been unable to collect this data for so long. Something that makes our nonprofit unique is that we've built trust with the communities that we're collecting data from. You know, we're not just like not consuming cannabis and then going to events and saying, hey, everyone, take this survey for 2 weeks. We are very, very open consumers online. At every event we go to, we're smoking with everyone. And we have built this community of trust that we won't misrepresent your data. We won't misrepresent you. And that you using this data and contributing to our study empowers us to want to share that back with everyone, to show you the research that we're doing and what impacts our research can have. We also want to listen to the community. Are there other things like 16% of people can't feel edibles? Are there other things like that the community knows, but maybe the research don't know? These are the gaps that we're trying to fill between consumers, academic research, and the cannabis industry, that there are major gaps in because we haven't built a network of trust. So nobody wants to share that data right now. But we find we're kind of in this unique situation where we're kind of operating outside of all those systems, but also slightly within them, that we're able to leverage that trust, gain that trust, and then share it back with everyone to have the most impactful data. And also this data, this survey, was created by consumers, which is, I think, why we're getting some unique insights, because we know what questions to ask cannabis consumers. Whereas if this was maybe government or academic research, the questions that they were asking might not be the most relevant to daily consumers or cannabis users in general.
So this is kind of our wrap-up slides is what we're going to be doing in the future and what we plan on doing after this. But we've been talking a lot about science as advocacy, and this is our stance on it as scientists, is that it's clear that daily consumers face stigmatization, that this leads to health inequities, and that it leads to unequal care and access. That the scientific research community and the medical community have contributed to this health inequity directly by the framing of research and by the funding of research that was specifically looking at cannabis only as a drug of abuse and only for negative and in a negative framework. And it still is. I have a friend who has a 12-year-old who wanted to do a middle school article. He was asked to do an article about health and science, and he said, I really want to do an article on how cannabis can help pediatric cancer, he said kids with cancer, to still eat during chemotherapy. And I said, that's beautiful, let's find an article. Now, he had to find an article that was from a traditional media source. He was not supposed to find a scientific article. So I pulled hundreds of scientific articles, and then I was like, great, let's look for where these are featured in the standard media. And I couldn't find a single one. And so we are still, and I'm not saying that that's necessarily science's issue, that is like an issue with media potentially, but it's also an issue with science, right? Like, because we are also responsible for the way that our research is interpreted if we do not take into our own hands how we communicate the information that we get. So it's the responsibility of scientists. I think it's our responsibility as pharmaceutical scientists to reverse some of these biases and some of this harm that has been done over the last few hundred years by specifically our field of research.
And we're going to talk about some future studies that we're doing that we're really excited about this year. The first one I'll mention is the science of smokability, or SOS. So we know that a lot of bud, flower, maybe it's dried and cured to a specific metric, or maybe it's cultivated in a certain way to have the highest yield and make sure that no bacteria or mold grow on it. But is that the best way for the actual consumer experience and the medical value and actually enjoying the smoking experience from that flower? We're not sure. So we're teaming up with our partner, Dr. Allison Justice at the Cannabis Research Coalition, and we are doing a series of studies. This isn't going to be just one or two. It's probably going to end up being about 50 different studies, where we're going to look at different cultivation metrics, but also different post-harvest processing. So the dry and cure process after we harvest that flower. How are we drying and curing it, and how does that affect the smokability and the consumer experience from a specific flower product? We're also doing a Weird Brains tour, and that's kind of something we've been talking about a lot, is weird brains. And really what this means to us, this could mean different things to everyone, but we believe it's really the cannabis neurotype, or people who react really positively to cannabis. It's not everyone, it's just some people's brains. And then of course there's neurotypes within that neurotype, where you have people who really like the uplifting cannabis varieties or the really sedating cannabis varieties. These are all kind of different neurotypes, or brains that react differently to different products. But we're gonna focus on the cannabis neurotype and how cannabis has essentially shaped weird brains and anarchists in society, because oftentimes we did have to hide how we were medicating, how many times we were medicating. Oftentimes this leads to not being compatible with traditional jobs that don't allow you to medicate or don't allow you to, go take a walk 5 times a day. And this also leads to a lot of entrepreneurship, a lot of creativity that the cannabis plant kind of assists our brains in finding new ways to get creative and figuring out a problem despite what society kind of wants those barriers to be. The cannabis community finds ways around that, finds our place, finds community in almost every single situation that we're in. And we want to talk about how our lives, how our brains, how our families, how our friends have been shaped around this amazing plant in a positive way, and how we continue to build community with that.
So we're going to take questions, but I want to thank Av so much. I want to thank Ren. I would like to thank the Scotian Cannabis Alliance for bringing us here and allowing us to share our research with you all. These are companies that are at the top, are our partners that help us with the technology for the survey. And these other companies are companies that we're working with that have supported the research that we do, and want to see an increase in what we do. And yeah, and this quote is this acknowledgement is really important to both Riley and I, and we tried to put it in the first paper that we ever published together. And they basically wrote back, Riley's like, I submitted it, I did it, I pressed submit. And then we wait in like less than 48 hours, they came back to us and said, this doesn't belong in a scientific presentation or a publication. And we're here on a mission with like what we're doing with our research to prove them wrong. So now Riley's gonna read it out loud.
Can you tell we tend to do things a little bit radical? So this acknowledgement says, to the legacy cannabis community who provided medicine to all in need during the prohibition at their own risk and expense. We realize that so many people went to jail, that so many people lost their families, lost so much money, lost so much community over trying to protect this plant and this medicine. And we realize everything we're doing is built off of these people and their sacrifices, and we wouldn't be here without them. And with that, we'll take any questions.
Yeah, and then one last statement that we all should definitely be thinking about expungement and ways that we could change that, at least within the US, but that it's not going to happen without all of us like knowing and acknowledging that it's still going on. So as scientists, we want to bring that forward. So thank you so much.
And just to make sure I heard Riley right, yes, Stewart Farms Arctic Relief and Stewart Farms Rebound are great topicals. Thank you. On behalf of the Scotian Cannabis Alliance, I just want to deep appreciation for Riley and Miyabi to give up some of their time and come up to Nova Scotia. It's been incredible. We had an event on Tuesday, and the industry was just overwhelmed by their knowledge and their advocacy. Please join me in thanking them for their time. Just want to remind you, on your way out, you'll see a pamphlet on the side, and there's a barcode on that. That gives you an opportunity to partake in their study. Once again, it's a longitudinal study, so you will be represented in the next time these data are presented. So, yeah. Thank you so much. Drive safe. Take care.